Wow.
Wow. Well, joining us to discuss this is the chairman, National Task Team on Antiretroviral Therapy in Nigeria, Professor Sulaiman Akomu. Good morning, and thank you so much for joining us on the show.
Yeah,
Thank you for having me.
Yes, he's also a professor of hematology and blood transfusion at the College of Medicine of the University of Lagos. Okay.
Yes, we will be expecting to be joined by another guest right there in our Abuja studio. But for now, let's... wow, you just listened to what some of the respondents there said. So many people are still very afraid. Like they say, ignorance is bliss. And a lot of people seem to have taken comfort in that. How dangerous is it? Let's even start there. Not knowing your HIV status.
Honestly, I'm intrigued with this.
The one that says the husband is a pastor.
Yes. It means we really have a big problem. Because UNAIDS thinks that by the year 2020, worldwide, 90% of people living with HIV and AIDS should have known their status. And by the year 2020, we should have been able to bring up to 90% of people who know their status to treatment. And we sincerely believe that with the kind of treatment that is currently available, we should be able to achieve the most important goal of asking people to swallow antiretroviral drugs. And that important goal is that the virus will no longer be detectable in their blood. And as long as you take this antiretroviral drug and the virus is no longer detectable in your blood, your capacity to infect sex partner is brought to zero. And if you are able to maintain this status by the year 2030, we should be able at that time be able to declare an end to AIDS epidemic, meaning that those who are living with the virus no longer are able to transmit the virus to other people, and they are living quality and healthy life, and no new infection is coming up. That is the target for the year 2030. But with what I've just seen now, people saying that I don't want to know my status, I'm living a faithful life, my husband is a pastor, I don't have a risk of becoming infected, it implies that those risk behaviors that we know is associated with transmission of the virus, the knowledge about it, the awareness about it is still damn very low. And this is actually the problem, because from the Nigerian statistics, not the world statistics today, we believe that nothing less than 3.2% of the age group that are at higher risk of becoming infected are infected, meaning that people between the age bracket 15 to 49. 3% of that age bracket are living with HIV and AIDS. And if you think that Nigerian population about that will fall within that age bracket will be between 70 to 80 million people.
That's a huge
We are saying 3.2% of that population are at risk of becoming HIV infected. And the truth is that we believe that on the whole, the absolute number of people that will be living with the virus in Nigeria will be about 3 million or 3.2 million people. As we are now in the country, we have about 1,057,000 people swallowing antiretroviral drugs out of the expected over 3 million that we think
there's still a
shortfall, the virus.
Major shortfall.
Where are the other 2 million people? Because if we don't find out these people and bring them to treatment, transmission will still be ongoing. And of course, WHO estimated, that only 52% of people worldwide know their status in Nigeria. And this group of people, and we have about 48% of people who do not yet know their status, that is worldwide. And these people are dying without knowing their status. The estimate as of 2017 is that 1 million people are dying worldwide of HIV/AIDS-related conditions because the status is not known. So when we say you have to know your status, we really know what we mean. And we cannot get the 2 million people to be brought to treatment if we really do not go out there and do the test. The truth of the matter is that for you to get 3 people who are HIV infected, you must have tested more than 100 people. So there's huge investment now in training on how to test, and a lot of strategies are now being brought up on how to get people to test. That's what they call partner notification services. For every one individual that we have identified, we want to screen everybody around that individual. If a child is one that is the index positive person, we want to test the other children in the family. If the mother and the father are not yet tested, we want to test them. If it is the father that is infected, really, we want to test the wife. We want to test others. Don't mind the woman that said her husband is a pastor. Because we know, the way it is.
The mentality there is that my husband is a pastor and I am faithful, like she was saying, so meaning that transmission of HIV is only by sex. So that's the understanding there. But let's go. To
a very large extent, that is true. In Africa, south of the Sahara, more than 90% of people who become infected through heterosexual sex. There are a number of other type of sex behavior that are now, taking the stage.
All right, yes. We'll come back. We'll come back to this. Now, from our Abuja studio, the Director, Community Prevention and Care Services, National Agency for the Control of AIDS, Alex Ogundikpe, joins us now from Abuja. Alex, good morning. It's good to have you join us right now. Now, Professor Suleiman in the studio has been giving us some statistics around HIV. But let me draw your attention to the issue of advocacy. Over the years, there has been sustained advocacy where when you mention HIV/AIDS, it no longer sends that panic in the minds of people anymore. But if you speak to people on the streets, we still hear, as at yesterday, as at this morning, people are saying they don't believe HIV exists. And others still don't know that these things are still very much available. How would you rate or assess the impact of advocacy over the years when it comes to the effect and the impact of that sustained advocacy over the years?
Thank you very much. And that is the irony of it. While we've succeeded largely with our advocacy, locally, nationally, and globally, we've got a problem with knowledge, with deepening knowledge among the population. And that is what you heard from the streets in Lagos, that there's a gap between what people know and just being aware that there's HIV out there. Over 90% of Nigerians have heard about HIV, and they do know about HIV. But do they know how it is transmitted? We've got a religious problem. Everybody feels they are religious, and so HIV is not their problem. That's another fallacy. Nigeria carries 30% of the global burden of the transmission of HIV between an infected mother to their child. And so that is an issue. We have succeeded in deepening, creating awareness, and we do no more create awareness by, you don't anymore see us on the street trying to just talk about HIV/AIDS. We are more interested in deepening knowledge and helping people identify their risk to HIV.
Let me stay with you, Mr. Alex Ogundikpe. Now, there's a troubling, issue that's arisen with, why Nigeria continues to record a rise, whether it's in mother-to-child transmission of HIV/AIDS, or even in the general population and all of that. That government seems not to appreciate how important it is, to actually fund HIV/AIDS, whether it's awareness and all of that, or treatment in Nigeria. Nigeria largely, to a very large extent, still relies on donor agencies.
You are very correct, and thank you for highlighting that problem. And that is what this government has been trying to change, and I will not mince word about it. Of the over 1 million people, 0.1 million people on treatment. Our partners account for about 1 million of them. It's sad. While the federal government understands this, and we've been trying to deepen ownership by getting governments, state governments, subnational governments to fund this response, it's been pretty difficult. And the reason is obvious. When HIV/AIDS was first detected in Nigeria, that notice was brought to us by our partners. And they largely were responsible for funding it. And so a lot of governments at subnational abandoned the funding of HIV to the partners. They saw it as partners' problem. And we're struggling with it now because most of our partners are withdrawing. Resources are dwindling. They've stagnated for years. These countries it's their taxpayers' money. But we're glad that significant changes are happening in terms of the funding landscape. Presently, the federal government of Nigeria is treating about 50,000 people in Abia and Taraba states. This is set to widen because His Excellency, the President, has committed to enrolling 50,000 additional every year, funded strictly by the government of Nigeria. As for the other challenge you mentioned, why Nigeria is responsible for over 30% of the burden of mother-to-child transmission globally, the reason is obvious. It is because of our bad health-seeking habits. Majority of pregnant women do not deliver in facilities. And so we miss the opportunity of testing them and of enrolling them on care. But there's a change that is happening now. Testing is we're encouraging the self-test, where because people are so afraid to test, to go to facilities to get tested. But the self-testing, with the launching of the self-test kits, it means you could just purchase self-test kits from pharmacies or patent medicine stores, and in the comfort of your house, test yourself. And if you find out that you are positive, you could then seek treatment, which is still free of charge in Nigeria. And we believe with that, we will be able to tackle this.
Okay. We'll come back to you shortly, Professor Akoma. Let me come to you on this. When it comes to issues of antiretroviral drugs, you mentioned it earlier on. How available, accessible, and affordable are they?
Before now, the affordability was a big issue. But today, the cost of treating a patient with HIV infection on antiretroviral therapy has really, really, really plummeted. Particularly if we are talking about what you're referring to as the first-line therapy. When you come to diagnosis and we are going to start you on treatment, we start you on what we call first-line therapy. I think I don't have that figure freely in my head now. I think per year of treatment with the available antiretroviral drugs, you probably will be spending about 72,000 naira per annum. But that will exclude the necessity to have to monitor the efficacy and necessity to have to monitor the safety, of treatment. So this treatment is largely made available for Nigerians now from donor agencies, as he has rightly pointed out. But I really want to dissociate myself from believing that the government of Nigeria is not funding HIV/AIDS treatment program at all. That is not very correct. The HIV/AIDS treatment program, there are what we call services: the testing services, the counseling services, the pharmacy services, the doctor-patient consultation services. And of course, you have an environment where you provide these services for this individual. Where we provide these services belongs to the government of Nigeria. I'm a government of Nigerian staff, and I'm paid salary every month because I'm working to treat patients that are HIV infected. I think my salary, if I'm going to pass it on to my patients, of course, the cost of providing those services to them will go up. I think Nigerian government is doing its part because those facilities are there. The water that we are using, the residue what we are using, our salary is a big chunk. And so all these partners that are talking about, yes, we thank them for the help because they are bringing to us this drug actually free to our patients.
Are you saying that there are no gaps created
There
with the donor agencies
but I don't want to believe that the
pulling
government
back?
of Nigeria is not doing anything.
No, nobody's saying they're not doing anything, but
We're doing enough.
Are they doing enough? That's the
So
question.
they could
so
do
that we
more.
can have, because
they could do
right
more.
now where
because,
we have,
because what we are saying,
Yes.
Is that these drugs are provided not by Nigerian government. That is one.
Okay.
Number two, what we call the most important test to monitor the efficacy of treatment, which is viral load testing, which is very costly, is not provided by government of Nigeria. So the government of Nigeria can actually do more. But I can also tell you that when patients fail first-line therapy, we move them to what we call second-line therapy, and they fail second-line therapy, and then we need to move them to what we call salvage or third-line therapy. No implementing partner presently in Nigeria is doing that for us.
Okay.
And the government of Nigeria has taken the bull by the horn. Okay, for those that these people have said they are not going to treat for us, and those are the ones that are actually the treatment for each of them, not 72,000 naira per annum, is going to be going to several thousands of naira. In fact, about 72,000 naira per month of therapy for this category of people. So
the Nigerian government should be applauded.
The Nigerian government
for what
has actually decided to do that and have
doing.
procured those drugs that are going to be administered to our patients. So I don't want to believe that our government is not doing anything.
Okay, let me bring Alex Ogundikwe in here from Abuja. Alex, when we look at the spread from either demography or the geography of where we live in Nigeria, from north to south, east to west, who are those more susceptible or who fall victim more of HIV/AIDS?
Demography-wise, thank you. Demography-wise, it is still the ages between 15 and 49 where the most at risk. Our age group, we are the most at risk. In terms of spread, we're doing something now. There is a national AIDS impact indicator survey that is going on across the country. The result of that should be out by March next year. It is the biggest survey being done anywhere in the world, and it is to give us the right size, the right information about our epidemic. And if we get that result out, we will be able to plan. You can hear some of those you interviewed saying, oh, they've never seen about HIV. It might be partially correct and true, but HIV is right there. We estimate currently that about 3 million people are infected. We don't know what will happen when we see that result next year. But I do need to let you know, the age most affected right now is between that 15 and 49. We have some above that are infected, and we have those below that are infected. But that is the productive sector of the economy that is most inactive, that is very, very affected right now.
Mr. Alex Ogundikwe, on the issue of self-stigmatization, on the one hand, there is stigmatization definitely going on, you know, and acceptance or lack of it. But how do you deal with self-stigmatization, where a person who discovers that they are HIV positive, you know, and they now believe that, well, it's actually a death sentence, not necessarily that they would die from it, but they shy away from having relationship or even thinking that there's any future, you know, for them getting
back into themselves.
Yes, you know, getting married to somebody and even having children. Let's look at the human angle of all of this.
Thank you very much. That is a valid concern. And we had this problem earlier on when people could not put face to HIV. When HIV was just being promoted out, no hope. Until we began to see people living with the virus coming out and saying, hey, I have the virus and I'm living well. Until treatment began to be scaled up, that was giving people hope. Now, a lot of that self-stigmatization is downward trend. And the more we deepen testing, the more we are able to, a lot of people cannot test today because they are afraid of the consequence of the test. But like Prof will tell you, it's a dramatic shift when you see somebody that is actually really, really down. And these antiretroviral drugs, they do wonders. You see people just recover dramatically, and there is hope for life. And the self-esteem of individuals. We see a record number of people who are living with the virus coming out now because they can see hope, they have high expectation. Unlike when it was just a death sentence. So the self-stigmatization is on the downward trend, and that's why we're encouraging people and promoting the self-test kits now, that people can, in the comfort of their house, check their status. And if you think if you are positive, if the result says you are positive, you can now go to a facility where there is treatment available, and it is free of charge, so that you can continue to live a purposeful life.
All right.
HIV is no more a death sentence.
Yes.
Okay. Alex Ogundikbe, Director, Community Prevention and Care Services at NACA, thank you so much for talking to us on TVC Breakfast. Right. Prof, let me come to you here. I know you would have heard some reports from rural areas where there are claims of people who can use local drugs or local concoction or local anything or medicine to cure HIV. Talk to us about that. Although we know that we know that certainly no one has really come out openly to say, okay, this is one. But there are some of these local news reports here and there.
Those local claims are even much better than the claim that the virus didn't exist at all.
Okay.
So because there used to be a time when people say the virus is not there, but the science of the virus today has advanced so much that we can look at the virus with our own eyes. We can monitor how the virus is moving from the plasma
the behavior
to infect the cell, how the virus is able to integrate its genomic material into the human genomic material. We are able to even mimic and see how the virus is replicating itself in the nucleus of the cell that has become infected by it. The knowledge about the virus is so fantastic. And today, the more we know about the viral replication cycle, the more avenues opening for us to mount therapeutic interventions.
And many people are already hoping that we'll find a total cure in the not too distant future.
The subject of cure is a big one.
It's a huge one.
And I can tell you, it's only a matter of time. Science will have the last laugh over this virus.
Okay.
Today, we accept we do not have a cure because of one very important property of that virus. The property is that when the virus gains access into the human body, what it does is that it packages its genetic material and transfers its genetic material into the nucleus of the cell and integrates its own genetic material with the human genetic material.
So there's a bond.
Such that the genes of the virus now appears as one of those genes that the individual inherited from his or her parents. And for as long as the human cell lives, the genetic material of the virus lives. Not until that day we are able to determine, to find out that particular molecule, that we go into the nucleus of the human cell, selectively destroy the genomic material of the virus without destroying the human
genome
before we'll be able to make a claim that final onslaught of the virus has come. But if people say they have a claim to cure the virus, I do not know much about that. There was this time around 2000 and 2003 when we have large number of claimants in the country who said they have cure,
including
and
a doctor.
The federal government of Nigeria actually has us to emphasize those claims, and they were big fallacies.
Wow.
Because when they say they have done their claim, to bring this person that you have said you have cured, and they will tell you, this is the virus there. This is the immunity that is so done.
Okay.
Worse, let me just mention this, because of churches that also say they cure individuals with HIV. These people have actually killed many of my patients. They will say, Prof, that man of God said I will get a cure. Just write a letter for me that this is what you are treating me for. I say, how could I write a reference to the church? Then write my death sentence. If you are not going to write, okay, I will write it. I take it there. They will come back 3-6 months later with severe immunosuppressive fever. And many of them actually die, of this disease. So this ignorance is a serious problem.
Okay, right. Professor Akomo, thank you so much. Professor Akomo Sulaiman is the chairman task team on antiretroviral drugs therapy in Nigeria. Thank you so much for enlightening us this morning. And as it has been established, HIV/AIDS is not a death sentence, and it's important to get early diagnosis so that you can, live a quality life. All right?
All right.